discuss, which is a very interesting case. Now, this is the disclaimer. There is no conflict of interest. Now, what is the learning objective of this clinical discussion case 2? That to select an appropriate and safe method for removal of fixed partial denture. Now, many a times in the clinics, we face this situation that we have to remove a crown or a porcelain fused to metal bridge or a zirconia bridge. Now, what is the various methods available which we can apply clinically for removal of these restorations, and what are the pros and cons that we will discuss? So, watch this full video till the end. And next, as usual, in the case 1, as we discussed, we will discuss that what are the various treatment options in the posterior rehabilitation in routine dental practice. And most important, and which is sometimes ignored, that the importance of occlusion in the success of restoration. So let us move forward. That what is the case context and this brief history of this case number 2. The patient was 45 years of age and he presented with chief complaint with pain and discomfort in the 4th quadrant, that is lower right posterior region. And he had a history of APD which was placed 10 years before. There is no other systemic illness present in this patient, and the one preference which the patient articulated, that he wanted a fixed restoration. So with this brief case history and case discussion, we will see that how we can manage this case nicely. So this is the intraoral picture. In this intraoral picture, we see that 5 units APD is present in 4-4, 4-5, 4-6, 4-7 and 4-8. Here 4-4 and 4-5 acts as an abutment, 4-6 and 4-7 is the pontic, and 4-8 is again abutment. Now we can see that this bridge is worn up and it needs remake. Now let us see that what the OPG and CVCT reveals. In the OPG, we can clearly see that 4-8 is failing, and we need to remove this FPD to save the 4-4 and 4-5 tooth, because the longer this APD will be present in the mouth, there is a greater chance that more damage will be done to 4-4 and 4-5. Now, let's summarize the problem list. So the problem list in this case is that there is a failed long span APD which extends from 4-4 to 4-8. Then there is a gum inflammation which is present in 4-7 and 4-8 region due to the furcussion involvement. There is a deep caries underneath 4-8 where the abutment is structurally compromised, and due to the furcussion involvement, we can see that there is a periapical pathology. So this is the problem list which we can summarize. Now, what are the various treatment options? Now, as I have said before, that the main preference of this patient is that he doesn't want any removal processes because he works in some high office. So he wants a fixed restoration for the confidence of speaking. So removal partial denture not acceptable. Now, if we consider the various options by which we can give the fixed restorations, there are 2 options. One is mixed implant tooth restorations. That means we place an implant in 4-7 region and connect a natural tooth with an implant and place an APD. And next is that we give a 4-4 and 4-5 PFM crown. That means we give a 4-4 and 4-5 PFM crown separately, and then place an implant in 4-6 and 4-7 region. So it will be separate. There is no connection between the natural tooth and the implant. Now, what is the comparison between if we consider this implant-supported FPD and mixed tooth implant-supported FPD? So this is the thing that we need to consider, that what are the pros and cons of these two treatment plans. So in support, if we consider only implant-supported FPD, it is totally supported by implants. So the implants and bone has got a rigid connection, whereas if we consider a mixed tooth implant-supported FPD, there is a difference in the tooth mobility of the implant and natural tooth. So it may cause some problem, and we will discuss. Next, the physiological movement between the implant and the natural tooth. We know the rigidity of union between the implant and the bone. So there is a minimum amount of movement when an implant is loaded vertically. That is only in the range of 3 to 5 micrometer. Whereas in natural tooth, the movement is in the range of 50 to 200 micrometer. So there is some difference. So this difference is very important that we take note. Next is the survival. Now the survival of only implant supported restoration is more than 90%. And if we consider the survival of mixed tooth implant supported FPD, it is close to 18 and 90%. So it is statistically not very different, but definitely the success rate of only implant supported crown or FPD is more when we compare with we mix a tooth implant supported restoration. Now occlusion, that is the most important thing that we should consider. So when we use only implant supported FPD, there is a light contact during centric occlusion. But when we use a mixed tooth implant supported FPD, due to the difference in the vertical movement of the tooth and the natural tooth only slightly contacts, natural tooth contacts slightly more compared to the implant in centric occlusion. That means when the patient bites in centric occlusion, the natural tooth moves more. So if there is an equal contact between the natural tooth and implant, the implant is subjected to more stress and there is a more chance of failure. So we will discuss that how we manage this thing. So how much heavier should be the contact on the natural tooth? So there is a important thing that we should consider, that when we place the restoration, we place a thin articulating paper both on the tooth and implant. And the thickness of articulating paper, that is naturally we use a good quality articulating paper like Bausch. So if we use a 8 to 12 micrometer articulating paper, and if we place between the implant and the opposing tooth, so it should just slightly touch and it should come out easily. But when it is on the natural tooth, it should be firmly held. But when we use a more thicker articulating paper, that is 14 micrometer, the natural tooth should mark, but implant should have only faint or absent mark. In this way, we load the natural tooth more compared to only implant supported restoration, and this compensates the difference in movement between the natural tooth and the implant. So we consider the treatment option 3. We don't consider mixed tooth implant supported restoration because of the problem we just discussed. So we place an implant in 4-6 and 4-7 region separately, and we place a separate crown in 4-4 and 4-5. So this is our treatment plan, that we place the implant in 4-6 and 4-7 and a separate crown in 4-5 and 4-4 region. So what are the various steps? This is very important. First is the successful removal of the old FPD. Step 2, extraction of grossly forehead decayed tooth, a traumatic extraction. Step 3, implant placement in 4-6 and 4-7 region. Step 4, prosthetic phase, PFM crown in 4-4 and 4-5 region, and implant supported crown after placement of PFM crown in 4-4 and 4-5 in 4-6 and 4-7 region, and the occlusion which I discussed previously, that the natural tooth is loaded more compared to the restoration supported by implant due to the difference in movement by using different dimension of articulating paper, namely which I discussed, 8 to 12 micrometer or 14 micrometer. So I articulate once more that when 14 micron articulating paper is used, it marks the natural tooth more compared to the restoration placed on the implant to compensate the difference in movement of natural tooth and implant. This is very important. So now, as in step 1, removal of processes. So there are different mechanism available to remove the crown and bridge, and that we have to just clinically, depending upon the type of restoration place, the condition of the restoration, and the comfort of the patient. That is also important. So this is the conservative approach. Here, air-driven, this kit is provided by Cavo, and pneumatic pressure is applied on the restorations, and the restoration is removed. So this happens only nicely when the underlying tooth structure is very nice and there is less caries, so that the chance of fracture of the underlying supporting tooth structure is less. So in this case, the restoration is removed with the cement in the intaglio surface. So this is the most conservative approach. Next is semi-conservative approach, where a hole is created buccolingually in the restoration, and in this hole a Wamke type of rigid instrument is inserted, so that it breaks the seals between the crown and the underlying tooth structure cement, so that the restoration is removed. So there is a minor damage to the restoration, and that damage can be restored either by composite or some other restorative material. Next is there is a complete destruction of the processes. We section the processes, as I have done in this case, to remove the processes because there was no other options considering the comfort of the patient. In this case, there is a less amount of trauma subjected to the patient and the processes is removed cleanly. But one disadvantage is that these processes cannot be reused again. So after removal of the processes, as discussed in the treatment plan, PFM crown is placed in 4-4 and 4-5 region. Now implant planning, we can see that there is an adequate amount of bone in 4-6 and 4-7 region. Implant planning is done digitally, and we can see that we can easily place the implant keeping in mind the safe distance of the vital structure. The guided surgical stent is prepared. It is placed on the cast to see the proper fit. Then it is placed into the patient's mouth with the key. We can see that there is a 2 millimeter diameter of drill which we used. That is the pilot drill, and the key is placed with the surgical stent in the patient's mouth. And the 2 implants in 4-6 and 4-7 region is placed with cover screw. Now, one interesting thing, after placement of the implant, I took an X-ray, and what I found that the cover screw in 4-6 was not placed properly. So had I not taken the X-ray, I would have mixed. So I advise that after placing a cover screw, it is very important. Even though implant is placed properly and you are satisfied, after placing also the cover screw, take a proper radiograph and see that the cover screw is properly placed. That gives a confirmatory test. So you can see in the right side that after taking the X-ray, I saw my mistake in placing the cover screw and I placed the cover screw properly. Next, just after the implant placement, we took an OPG X-ray. The implants are properly placed and it is in the bone without any loss of bone. After that, we place the healing abutment, and we can see the healing abutment has healed properly, and we can now move to the impression phase. So in impression, we decided to take an open tray type of impression for more precision, and we can see that impression coping is placed into the patient's mouth, and then we will adjust the tray for the ease of placement, and then we will take an impression with suitable impression material in the open tray technique. After the impression, we place the abutment and we select the abutment considering the gingival height, the occlusal clearance, and the diameter which will be necessary to take the load in the posterior region. So the process is in place, and this OPG is X-ray 6 months after the placement of implant and the restoration, and we can see that the implant and restorations are in a good shape and the process is functioning nicely. And this is the intraoral picture with the 2 PFM crown and 2 crown on the implant, and this is in occlusion. This picture, this shows the restoration. Now, what is the summary of this case discussion? The summary of this case discussion is that whenever we plan a treatment, the patient opinion and expectation should be taken into consideration. There may be various treatment options, but the options which suits both the clinician and the patients are to be considered. Long-term prognosis of the restoration is especially important when the patient is young, because we should plan a restoration keeping in mind the long duration. Suppose the patient is 30 or 35 years of age, we should discuss with the patient that suppose I plan a restoration to last 20 years, so that you are healthy and able to chew till the age of 60. So the patient will understand that you are really considered for his long-term dental health. A thorough understanding of occlusion is necessary. Without thorough understanding of the occlusion, the long-term prognosis of the processes will not be achieved nicely. And at last, regular follow-up and proper patient instructions are essential for the long term of the restorations. Thank you.